This is Jennifer Lewis. Like Haley said, I work in the Department of Urology. I think it's a common misconception that urology is a men's area, but we do a lot of female pelvic health and other problems that can happen in the urologic field. So I did this presentation last year, the year before, and it's pretty similar. So if you saw that, it might be reviewed. Some of it's been updated. But essentially, I have nothing to disclose. What we're going to kind of cover is some basic anatomy and physiology, some of the common things that we see here in urology, and specifically with female urology and women issues, which range from urinary incontinence to pelvic organ prolapse. A common one we see is urinary tract infections versus cystitis, which we'll talk a little bit more about. Voiding dysfunction and what that means, and kidney stones, and just kind of an overview of some of those treatment options that we have for some of those. So if anybody is familiar with the anatomy and physiology, I apologize for some of this review, but obviously there's an upper urinary tract and a lower urinary tract, and specifically in urology, we usually deal mostly with the lower urinary tract, which is primarily bladder, urethra, pelvic floor. But essentially what the urinary tract does for our body is it gets rid of the waste through our kidneys and into our bladder and out. The bladder functions to kind of store that urine in between the times that we can go and actually eliminate it. When I refer to the detrusor, that is the actual name for the bladder muscle. And the bladder muscle, or the detrusor, is what's used to squeeze the urine out to empty effectively. The urethra is the exit tube where the urine leaves the bladder. And the pelvic floor muscles are the actual muscles that most of us are familiar with as far as like Kegel exercises. And they help not only, support the pelvic floor, but help keep things kind of aligned and functioning properly. So this is kind of a basic elementary explanation of kind of what happens once our bladder is full. So essentially the bladder or detrusor is relaxed, your sphincter muscle is closed or contracted, and your bladder slowly fills over time, regardless of what you're drinking, when you're drinking. It's always filling. Obviously, if you drink more, you're going to fill faster. But when you're ready to urinate, what happens is you get this first sensation to void, and that's going to tell your bladder or tell your brain that, hey, your bladder's getting near capacity. Let's try to find a toilet or maybe take the next exit. And then obviously once you get to the bathroom, if everything's working like it should, then obviously your brain will then tell your detrusor, okay, we're gonna do this. And then your sphincter muscle will relax, and then you're able to empty, and then the bladder will start all over again. So we'll start first with urinary incontinence. We see a ton of urinary incontinence here in urology. About 1 out of every 2 women and 1 out of every 4 men will experience some sort of incontinence at some point. There's really 3 major types of incontinence. There's urge incontinence, which is like the little lady waiting to go to the bathroom who can't quite make it. That's because with an urge, you actually leak urine. There's stress urinary incontinence. And if there's any of the ladies who have had babies or had weight changes, you may notice that you can't jump on the trampoline anymore like you used to, or jumping jacks or running. That's called stress incontinence, and that's because the sphincter around the urethra, that muscle, isn't as strong as it used to be. And then commonly, we also see mixed incontinence, which is where you actually can have both. And we actually see that quite commonly. Usually there is something going on that's contributing to having the incontinence, and that's kind of part of our job, is to figure out if there's something treatable, reversible, that we can obviously treat. But incontinence is typically not just an expectation of getting older. There's another type of incontinence called overflow incontinence. It's not as common, but we do see that. That's where your bladder just doesn't empty all the way out, and then if you want to look at it as a glass, your glass is kind of overflowing. But we're not going to get into that too much. So risk factors for incontinence. Obesity, obviously, excess weight puts strain on the pelvic floor and it weakens it over time. Same with pregnancy and childbirth. Again, that fluctuation in weight on the pelvic floor just weakens, and then we just can't hold it anymore. Constipation, when you have irregular bowel movements, it can also impact bladder function. Menopause, just because of the changes that happen in the vagina with that loss of hormone, which we can talk about a little bit later. Limited mobility, obviously, if you have a hip fracture or some other condition that makes it harder to get to the bathroom in a timely fashion, that's obviously going to lead to incontinence. Certain medications can worsen leakage. Diuretics or water pills, sedatives can help, inhibit the brain from acknowledging those urges that we need to go urinate. Smoking is kind of a twofold. Smoking is the #1 cause of bladder cancer in women, but it's also an irritant to the lining of the urothelium in the bladder. But also for incontinence, smoking can lead to chronic cough, which over time can worsen stress incontinence and weaken the pelvic floor. There's dietary contributors. I believe I talk a little bit more about that. There's things that we eat and drink that actually irritate our bladder and lead to an overactive bladder condition. Prior surgeries, whether it's vaginal deliveries, whether it's any other kind of pelvic surgeries, there's surgeries that can also lead to worsened incontinence. And then obviously there's the understandable ones of just chronic diseases that we see a lot. We see a lot of diabetes. Uncontrolled diabetes can wreak havoc on your body, but for the urologic standpoint, you can just make your bladder stop working as well. It can make you make more urine. There's a lot of physiological processes that happen there. Neurological processes like multiple sclerosis, Parkinson's disease, spinal cord injury, or we see tons of patients with congenitalism like spina bifida that can have bladder problems. So let's go back to urge incontinence. So urge incontinence, like this little old lady, she's trying to scoot to the bathroom. It usually happens when you need to pee or you have that strong urge and it's happening before you make it to the toilet. So that's usually where the term overactive bladder comes from. That means you are urgently seeking a bathroom at frequent intervals, about, we'd say normal urinations every 2 to 3 hours. If you're going any more than that, then obviously that's considered excessive. Stress incontinence. So that actually is the most common type of leakage. See a question over here. I have to come back to that. Most common type of leakage, stress incontinence. It usually occurs, like I said earlier, with laughing, coughing, sneezing, exercising. So that pelvic floor is just weak, and that's where they tell you, you got to do the Kegel exercises, and we'll talk about some of that here in a minute. So mixed incontinence is the combination of the two. You can leak because you need to pee and can't make it, but you can also leak if you try to do some jumping jacks or yoga or something like that. So the basic conservative treatments that you can do for either type of incontinence is kind of the basic dietary behavioral changes and bladder retraining. Unfortunately, I see a lot of healthcare providers, teachers, truck drivers, people who just over time have developed these bad habits to where we don't have time to go pee when we should. And so the basics is really where we need to start. So the basic ones would be, making sure you're not excessively drinking all the wrong things or in too much excess. The dietary things that I talked about would be like anything caffeinated, carbonated, spicy foods, acidic foods. There's a whole list of things that are actually known dietary triggers that people should try to avoid or look for something that's worsening their symptoms. Timed and double voiding is just a way of saying you need to make sure you go pee every 2 to 3 hours, like I talked about earlier. Even if you don't have the urge, just kind of prompt yourself that, hey, this is when I should be going to pee, and retraining yourself. Double voiding is another maneuver. In some cases, patients don't feel like they're completely emptying their bladder, or maybe they they aren't completely emptying their bladder. And so we will discuss double voiding. Obviously, one of the number one contributors was, excess weight. So weight loss is something we talk about. The weight loss and smoking cessation are the hard ones because obviously those didn't happen overnight. Those habits are lifestyle changes that will take a lot of effort, but will yield great benefit if you were able to be successful with those. Kegel exercises are pelvic floor physical therapy. If we're dealing with stress incontinence or just pelvic floor laxity, just weakness in the pelvic floor overall, Kegels is a good start, but unfortunately, probably 80 to 85% of patients who do Kegel exercises do them inappropriately once they're, tested to be doing them. They're usually squeezing their abdominal muscles instead of actually using their pelvic floor like they should. And so there's actually physical therapists. There's some on campus, and we have some around the metro area that we can refer you to that can help you strengthen that pelvic floor. And the great thing about physical therapy is there's really no side effects other than you just got to do them. Occasionally we do a voiding diary. The voiding diary will help us with, fluid control, or if we're worried about excess water intake or fluid intake, then we can look at a voiding diary, and that'll tell us pretty much what your intake is, your outtake is, and make sure there's no discrepancy that's contributing to some of these symptoms that you may be having. Some instances there may be an indication to use a pessary. There are pessaries that are used for pelvic organ prolapse, which we will talk about here in a little bit. But there are these new devices that I have some samples of that actually help to put a little bit of pressure onto the urethra. They're over the counter, and they can help with stress incontinence. They're similar to a tampon. I have had patients who've told me about them and used them. I don't prescribe them regularly, but there are lots of over-the-counter products to help with incontinence. It's kind of big business. But the big thing I think that I see most frequently is that people just need to work on their comorbid conditions, their diabetes. Frequently, I see people who have severe incontinence, but their diabetes is so poorly controlled. And that's not really a lower urinary tract problem. That is more of an emphasis on the upper urinary tract and your body's way of trying to rid some of that sugar from their body. So I see a lot of diabetes. Urge incontinence medical therapy. So back to the types of incontinence. Urge incontinence, there are medications, right, for overactive bladder, and they work to kind of relax the bladder or calm the bladder down. There's probably 8 to 10 of those. Some of them may be familiar. There's Vesicare. You've seen the commercials with the leaky pipe people walking around. There's Detrol, Ditropan, Oxybutynin. There's lots of different names. But they all work very similarly, and they all have similar side effects. And those are dry mouth, dry eyes, constipation, some cases confusion, and sometimes urinary retention. So that can also be bad. If you remember, bowels is a big thing. We don't want constipation because the bladder can't work well. So sometimes when we give these medications, it comes with the caveat that they also need to, get on some medication or some therapy to help them have regular bowel movements. One of the newer medications, it's not as new any longer, it's been around for a few years, is Myrbetriq or Mirabegron. It's a beta-3 adrenergic agonist. It also works as like an antispasmodic, or makes the bladder relax and have less spasms. Doesn't have quite the side effect profile of the anticholinergics. Usually with that one, we want to make sure the patient doesn't have any underlying cardiac history, high blood pressure that's not controlled or undiagnosed. Back to the anticholinergics, a new thing that came out not too long ago is long-term use of that group of medications has been linked to worsened dementia and Alzheimer's patients in the elderly. And so we've become even more cautious about who we prescribe those medications to. Additionally, for urge incontinence, back to where we talked about menopause, usually after menopause, you have this lack of hormone, and without that hormone, the vaginal tissues become thinner and drier and weaker. And so one of the things we can do is replace some of that hormone with like a topical estradiol if we're able, there's no prior breast cancer, and that can just improve the vaginal tissues and integrity. Okay, so if the medications and behavior stuff fails, then there are some surgeries that we can do. And some of those are a little more invasive than others. One of those things, there's a technology called neuromodulation therapy or nerve stimulation. There's really two types of that. There's tibial nerve stimulation. That's where down in your ankle where your tibial nerve runs, and actually stimulate that nerve. And it in turn stimulates the nerves to the bladder and kind of resets it. That's why we call it a bladder pacemaker in this technology, because it's similar to a cardiac pacemaker, but we're trying to reset the bladder so that the bladder cycles a little better. Sacral neuromodulation is more common, I would say. The tibial nerve one is usually done in the office with weekly treatments, which can be kind of inconvenient. The sacral neuromodulation, we can actually do a test in the office, and if it's successful, we can actually implant this little pacemaker device. In January of this year, they made improvements, and now there's a competitor of Axonics and Medtronic, and now they're kind of going together, and they have rechargeable ones, so you don't have to worry about the battery replacements, and they're MRI safe and compatible, which is fantastic for some of our neurologic patients, specifically like the MS patients who require MRIs frequently for their neurologist. Another surgical procedure that we do is bladder Botox injections. It's the same type of Botox that's used for wrinkles, headaches, everything else under the sun, but you can actually inject the Botox into the bladder, the detrusor muscle, and relax the bladder. And it provides temporary relief in that it relaxes that muscle to where hopefully you don't have to go as frequently and you don't have those spasms and that urgency as often. About 1 in 10 patients with that therapy, it works too well. So we trade leaking for retention, but it's still a very safe and relatively successful treatment option. In the extreme cases, you can do an actual bladder enlargement where we actually augment the bladder with a piece of bowel. And there's a little picture on there where we can just kind of give it a little patch to just give you more capacity if that's kind of the bladder's problem. Stress incontinence. So remember, that's the incontinence that's purely with activity. There's really not any good medicines for stress incontinence, because remember, that is a weakening of the pelvic floor and the urethra muscle right there. So there's not medicines that help with that. So typically, if you fail the conservative treatments, the weight loss, the physical therapy, the Kegel exercises, then it's usually a surgical procedure. The mid-urethral sling, as you can see that from that little picture, is like a little piece of tape of mesh that goes kind of behind the urethra and works as like a little support hammock, so that when you cough really hard or you sneeze really hard or you jump and you put that excess abdominal pressure into that area, it can kind of help give you a little bit more support. The other, and you can do that with mesh product, or there's also autologous, meaning we can actually harvest your own tissues and kind of create a little sling in that area. The other option is urethral bulking injections. So if you can see from that other little picture down there, that agent used there is called coaptite, where we can actually put little bulking fillers on the sides of the urethra, and that again puts that little bit of extra pressure right there on the urethra. Pelvic organ prolapse. So pelvic organ prolapse is effectively a female hernia, right? So it's a weak area in the pelvic floor where our female organs can kind of protrude through the vagina. That could be the bladder, that can be the uterus, that can be, if you've had a hysterectomy, it can be just the vaginal vault or the inside of the vagina. You can have enterocele, which is where the intestines can actually kind of protrude down there, as well as the rectum, which would be rectocele. Many times this can be asymptomatic, and it's pretty mild forms. As it becomes symptomatic, what you're really going to see with that is a noticeable pelvic vaginal pressure, fullness. You may even feel a bulge in the vagina. May even have changes to how you urinate and how you have bowel movements. It may be harder to empty your bladder. It may be harder to, pass stool. So that may be one of the noticeable symptoms. In some cases, the bulge may be so severe that you actually have to push manually, reduce or push those tissues back in order to eliminate. In some cases, that can cause issues with intercourse, understandably, just from how it sounds. But typically, it's not necessarily painful. It's just kind of altered. But when it alters, the anatomy that way, it can lead to bladder dysfunction and UTIs if the bladder's, tends to not empty well, or it changes the bowel movements patterns. So types of prolapse. So this picture here is going to show you kind of the normal anatomy. This lady still has her uterus, so no hysterectomy here. But effectively what happens is the vagina is the weakened area, and so everything kind of turns like an inside out sock. So everything kind of protrudes out the vagina, as you can see there. And it can be a combination, just like with the types of incontinence. It can be multiple. It can be bladder and bowel. It can be bladder and rectum. Pardon me. But it can be a combination of the types there. So the risk factors, again, are similar to the bladder dysfunction and incontinence. Obesity, again, it has that increased abdominal pressure and therefore weakens that pelvic floor again. Again, pregnancy and childbirth, advanced age and hormone changes. If you've had a hysterectomy, believe it or not, it's not a protective mechanism for this type of defect. So, for whatever reason that you have to have a hysterectomy, that uterus kind of served as like an anchor for the, pelvic organs. And so when that is removed, you are more predisposed to having a prolapse. Chronic constipation, that constant straining to have bowel movements, it just again further weakens that pelvic floor. The cough we already kind of talked about, just like it causing weakening of the pelvic floor for leakage, it can cause the weakening for the pelvic organs themselves to prolapse. And prior pelvic surgeries, vaginal surgeries, vaginal deliveries, episiotomies, things like that. Okay, so treatments for prolapse. So if you have no symptoms and somebody mentions, oh, your bladder looks like it's falling, you really don't have to do anything if you're not having any symptoms. You do want to, be aware of it. And, if you know that you have it, then obviously you're at an advantage to try to prevent it from worsening. Additionally, if you are symptomatic, there are the behavior modifications, which we already talked about, the diet, the time voiding, the avoidance of constipation, the pelvic floor physical therapy, the PFPT, pessaries. I think there's another slide on pessaries. So pessaries are these vaginal insertion devices that actually help hold the pelvic organs in place to keep from falling through the vagina and prolapsing. And then obviously, one of the risk factors is postmenopausal hormonal changes. So replacing the vaginal hormones can help improve the integrity and lining of the vagina, and that can kind of help improve some of the symptoms associated with pelvic organ prolapse. And then obviously there's surgical repairs, which we will talk about. Urinary tract infections, cystitis. So I see this a lot. People get sent to urology for recurrent urinary tract infections, when in actuality they may just have cystitis, which is just a fancy word for inflammation of the bladder. Well, UTI is cystitis. That's kind of confusing, but UTI is caused by bacteria, and cystitis is something else causing the irritation. So symptoms of a UTI. Yes, you may have the burning, painful urination, the urge and the frequency with very little amounts, the pressure, may even have a leakage. You may see blood in the urine and fevers, tiredness. In the elderly, they actually may be like acutely confused. But typically it's not the odor, it's not the color. Those are just more indicative of things that need to be done, like drinking more water, peeing more often. But the classic symptoms of UTI are kind of right here, which can be similar with cystitis, right? So it's similar to UTI, but there's no evidence of bacteria. So they may check a urinalysis and say, yeah, you have a UTI. But if we send it to the lab, the cultures actually won't grow a bacteria. Doesn't mean you're not having symptoms, it just means it's not bacteria related. But they're usually those irritative symptoms, again, the urgency, the frequency, pain, dysuria, just burning with urination. But most of the time, cystitis is caused by something that's triggering your bladder to be irritated. See tons of women who are, going through a lot, being stressed, and they'll notice their bladder symptoms are more noticeable or bothersome. Some women, intercourse can actually be a trigger of having cystitis events. And we've already talked about smoking and diet and the bowels. So that's kind of, the deciding factor is if it's UTIs or cystitis is if there's actually, bacteria present at the time that we're checking. But both of them are going to be the same as far as treatments with or without antibiotics. So if you do come and see, urology, and we determine, yeah, you are having recurrent urinary tract infections, then we're going to talk about, well, why would you have these? And we would do, kind of an in-depth evaluation to see if there's some underlying condition as to why you're having the UTIs. But most of the time, it's going to be the same in both conditions on how to prevent having these episodes, whether it's infection or cystitis. Again, it gets back down to the prevention with peeing like you should, pooping like you should, eating like you should, and avoiding all of those things that we know are bad for us. Avoiding dysfunction, so that's kind of a catch-all for some of these bladder conditions that we don't really know a whole lot about, but we know things just aren't right. So it can be urgency, frequency, it can be difficulty going, it can be straining, it can be, I need to pee, and you get there and the flow just won't start. But there's many different reasons of why it happens. It can be because of an overactive bladder. In some cases, it can be an underactive bladder. We see patients who their sphincter muscle just won't relax when it's time to pee. There may be some sort of nerve disruption from a prior back surgery or back injury. There's just a whole slew of reasons as to why they're having this dysfunction of elimination. Maybe a chronic issue. We see tons of patients who they've been having UTIs or problems, with their bladder and bowel since they were children, and it just persists into adulthood. So obviously, just like anything else, if there's some coexisting contributing disease that's going on, we want to try to figure that out and treat that, because that would be the #1 cause for some of this dysfunction. Again, basic behavior conservative treatments, the same as incontinence and UTIs. Got to make sure we're peeing every 2 to 3 hours. Make sure our bowels are regular. And then the treatment, there's different pathways depending on which way you go. So if it's an overactive bladder, then we go back to kind of our overactive bladder pathway with the sacral neuromodulation, the Botox, the medications. If it's, a combination of other things, we may consider the pelvic floor physical therapy, which can include biofeedback, which is where the physical therapist can actually help us determine kind of where the breakdown is and give you like a plan on how to, work on some behaviors and exercises at home. Kidney stones, I won't get into too much, but we see men and women with kidney stones alike. But typically what happens is about 12% of Americans get it. And once you've had one, you get a 50% likelihood of having another kidney stone. And you don't have to tell somebody what a kidney stone is like if they've had one before. Obviously, it can be described as worse than childbirth, so we don't really want them, but your risk for having them are obesity. There's dietary reasons. Sometimes it's your genetics, so you can blame it on your parents. And then, you know, more recently it's come to light certain medications, like there's some seizure medications that can predispose you to having kidney stones. We see patients who've had bariatric surgery, primarily like a Roux-en-Y procedure for weight loss maneuvers, that can come in with kidney stones. But typically the symptoms would be, you may have blood in your urine, you may have nausea and vomiting, but typically the classic sign is that sharp pain in the flank that isn't really related to any activity or anything you're doing, but it's indescribable pain. So if you've ever had it, you would know. As the stone passes, you may or may not start having bladder symptoms like a UTI. You may have blood in the urine. Like I said, you may have that urgency, that frequency, that burning to pee, very similar to a UTI. The most common type of stones, as you can see on here, it's about 80% or 75% is calcium-based stones. And that's not because of an excess of calcium in your diet, but more so related to other metabolic reasons. You really want a normal calcium in your diet. But this just kind of gives a good overview of what the symptoms are, the risks of it. But typically, to diagnose a kidney stone, you're going to come in with some symptoms, but typically you want to have a confirmatory imaging, typically a CT scan. Plain x-ray can do it sometimes to kind of confirm for us what we're dealing with. Depending on the size and location of the stone, we may be able to give you a trial to pass it. Watchful waiting, we try to catch it if you can, so we can see what type of stone it is and try not to do it again, because it's not fun for anyone. But if you're not one of the fortunate ones who can pass the stone, then obviously there's some surgeries that can be done to help alleviate the stones. So there's the lithotripsy or the ESWL. That's where we use shock waves to kind of break up the stone. There's a ureteroscopy. So that would be where we can use little cameras and lasers and baskets and try to remove it. PCNL or percutaneous nephrolithotomy is where we can actually go into the kidney from the back and try to remove the stone. And then there's some other stone procedures that are less commonly used to treat the kidney stones. But how do you prevent these things? Drink lots and lots and lots of water. I don't know how many times I can say that. That's the #1 cause of kidney stones. In the summertime, I think our stone incidence goes up twofold, because obviously in the summer, we're using up that water as much as we're drinking it. So you even have to compensate even more if you're a stone former. But as a rule of thumb, 2.5 to 3 liters of water a day is kind of what we mention. And the reason why is the more dilute the urine, the less likelihood of those stones to kind of precipitate and collect together. Like I mentioned before, normal calcium, even though it's a calcium stone, it's usually the sodium in our diet. So the frozen foods, the boxed foods, the soups, all of those things that have a lot of preservatives with salt, those are the #1 culprits of the diet reasons for stones. If you are a stone former and you've had a stone before, or you have family history of stones, and then you have a stone, then we may want to do a more formal evaluation to see metabolically, is there something else that your bladder's doing or your body's doing to predispose you to make stones. You know, if you have a hyperactive parathyroid, that would lead to, you know, excess calcium levels, and then that will lead to stones. There's a whole slew of other reasons why you may be making stones. So in conclusion, there's a lot that we talk about. Again, urology is not just about men problems. There's a lot of women issues that we do in urology. And we talked about, you know, several of those, but there's a lot of conservative treatments, but there's also some surgical and medical treatments that are available for some of these conditions. I don't know if anybody I had one question. Does the urge to go to the bathroom more frequently than usual, but having control until you get to that count as incontinence? So Frequency, again, is defined anything more excessively than every 2 hours. If you just drank 3 pots of coffee, then yeah, you're probably going to have to go more frequently than every 2 hours. So it's got to be within reason. But if you have the warning from your bladder that it's time to go pee and you don't have enough time to get there and you're leaking before you get there, then that would be kind of defined as incontinence. That's a good question. So is there any hope to get off of an overactive bladder medication, or is it likely you will have to take it indefinitely? I have that conversation frequently. So an overactive bladder medication isn't really doing anything to the bladder. It's not eliminating what's causing the overactivity of the bladder. It's just controlling the symptom of it or improving your quality of life. So the only way to get off the medication is if you can really kind of hone in on what's causing it. Again, the bowels is a big thing. Although this is the pee office, I do a lot of poo talking. Probably about 85% of the patients that come in here have some sort of bowel irregularity, usually constipation. So there's usually something or an area to work on to try to get off of the overactive bladder medications. Now, if the medications you've tried to come off of and you've failed and you've tried some of those other conservative treatments, then you may graduate to some of those other, non-pharmacological or non-medication pill forms of treatments like the PTNS or the sacral neuromodulation or the Botox. But there's, as far as using it indefinitely, it's a quality of life issue. So it's really not one of those things that you would have to, but if it doesn't go away and it's still bothering you, then yeah, you may have to be on it. Can you recommend good resources for help with IC network? So interstitial cystitis, or IC, for anybody who doesn't know what IC stands for, I kind of highlighted that a little bit with the cystitis versus UTIs. There's a whole online network. There's a lot of resources for IC. IC is a diagnosis of exclusion, and so it's really hard to make that diagnosis without eliminating some of the other reasons of having, those cystitis-like symptoms. But usually it's just management of triggers. I kind of highlighted some of that, but if you can avoid those triggers, there's plenty of medications for, management of the symptoms. A lot of patients are on some sort of a overactive bladder symptom course with like an anticholinergic treatment. The bowels, we have a lot of sacral neuromodulation, Botox. There was a medication that some people are still on with IC called Elmeron. Elmeron's kind of come to light lately because it's been linked to some side effects with retinal changes that have been permanent. I think there was a letter from Dean McGee. We had sent some patients over to be evaluated, and they've actually kind of taken notice that they've had retinal changes after being on Elmeron for a while. But as far as IC, interstitial cystitis, there's definitely a lot of resources. There's probably more online than I could even talk about for days. But as far as treatments, it's very individualized, and that's almost its own topic. Is it pretty reliable that as long as you stay well hydrated? Yeah, so the kidney stones, no family history of kidney stones. It's kind of terrifying thinking about getting a kidney stone. Even myself, every once in a while, I'll get a twinge in my back and hope to God it's not a stone. So, I mean, if you drink plenty of water, the likelihood of getting a stone is probably pretty low if you don't have family history. But I mean, there's hope if you do. Don't feel like you're destined to be cursed if you do have them, but definitely drinking lots of water is your safest bet. And, like I said, low sodium, low oxalate, which oxalates and everything, but sodium in the water is the big stuff. Started getting used to 14, and I have had 17 stones over. Are there any new research medications that can help dissolve stones in the kidney? Any supplement use? So again, with kidney stones, so If you're that aggressive of a kidney stone former, if you haven't, you should probably see a nephrologist. They kind of help the urology side out. You don't know what a nephrologist is, they're the kidney doctors, so they're the medical doctors of the kidneys. We're the plumbers or the surgeons of the kidney, so we help treat the kidney stones. We do try to do some prevention and workup for them, but once you've had that many, usually you should see a nephrologist. But being that most stones are calcium oxalate for the majority, there isn't a medication that will just specifically dissolve them, because obviously calcium is like bone, so it's very, very dense and very strong. And so typically there's not anything once they're formed to dissolve them. There are stones like uric acid stones, which there are medications that you can take to help dissolve them. But as far as like supplements and prevention of stones, usually if you already have a stone, you want to try to get the stones cleared if you're able to, because obviously if there's stones still there, they can continue to grow and form new stones. But if you drink plenty of water and do the dietary things, that would help prevent some. But if you're to the point where you've had 17 and 27 years, then I think you've kind of graduated to what we say a metabolic workup to really try to hone in on what we can do differently to help prevent some of those kidney stones. Cranberry supplement, that's a good question. I get that a lot. So cranberry is a supplement. Any of the herbal, supplements that you get, unfortunately, are not regulated by the FDA, and so they don't have as much research behind them. Fortunately, cranberry is one of those that's been around for urinary health for so long, it has quite a bit of research behind it. But the kicker is the research is mixed. So the jury's still out. There's research that supports the cranberry, and there's research that found no difference in placebo. My take on cranberry is cranberry in general is very acidic. So some people, acidic foods are very irritating to their urinary tract. And so those are the patients I say, if you feel like it's helping, let's do it. If you feel like it's making things worse, it can be acidic, so we should probably stop. But there's really not a right or wrong answer on the cranberry. I'm kind of on the fence. If people feel like it helps, then I say continue it. What is the average amount of time between drinking something and it passing through your system as waste? That's a good question. I don't have that kind of readily available, but I will tell you that anything with caffeine and carbonation will go through a lot faster because it has a diuretic property. So that's why I kind of mentioned the coffee. You drink a soda, if you drink tea, alcohol is another one that's a diuretic. It's going to go through a lot faster just because of the caffeine and the alcohol associated with it. But as far as, that's a good nephrology question that I don't have, so I don't know how quickly it would, but you're constantly making urine. It can be more so depending on what you're drinking and how fast it actually gets processed into your bladder. Any other questions? If there's anything that you guys are interested in learning more about, you can obviously email me. If you're having, issues that you want to talk more about with me, I have other female nurse practitioners that I work with. I also work with a great group of urologists who are always available. You just want to give our office a call, we can get you in and we can talk about, whatever's bothering you. And, if you've tried other treatments, if there's other treatments you're interested in learning more about, we would be happy to see you.
All right. Thank you, Jennifer. As she said, if you have any questions, you are welcome to send her an email to reach out to her. Don't forget, if you are trying to log this for wellness points, you can log it under the physical dimension of wellness as a physical wellness workshop. Again, thank you for presenting to us and educating us on this topic.
You're very welcome, Kaylee. Thank you.
Thank you.
All right. Bye-bye.